Good morning, everyone. My name is Kelly Bauer, and I thank you for joining our presentation today on the development of a community and patient-engaged maternal health equity toolkit for hospitals. My team and I are from MD Mom, the Maryland's Maternal Health Innovation Program. I myself am a public health nurse and faculty at Johns Hopkins School of Nursing. I'm joined by several colleagues who will be presenting here with me today. Lauren Arrington is a nurse midwife in a Maryland hospital, and she is faculty at Georgetown School of Nursing. Tanae Harris is a lactation specialist, perinatal educator, and postnatal doula. She is also director and co-founder of the Bloom Collective, a Maryland community-based organization that's a collective of reproductive health and wellness practitioners. And finally, Brianna Kramer is a nurse midwife, a research associate at Johns Hopkins School of Public Health, and a program manager for MD Mom's Hospital Equity Initiative. This team has really led the development of the Maternal Health Equity Toolkit, and we're really excited to be here today to share it with you. Our learning objectives for today's presentation. First, we'll look at the importance of engaging patient, family, and community partners in hospital-based maternal health equity work. We'll share the 5 priority areas that we have identified in our maternal health equity toolkit for promoting equity in maternal health hospital settings. We will dive deeper into several of the equity-focused recommended strategies and change ideas that we present in our toolkit. And we'll talk about individuals and groups who should be engaged in hospital-based equity work. I'll provide just a little background about the MD Mom program. This is the MD Mom website. It's mdmom.org. The Maternal Health Equity Toolkit is really part of the larger Hospital Equity Initiative, which I'll describe a little bit in a moment. And the Hospital Equity Initiative is one of 4 areas of innovation in the MD Mom program. You can see the others here in the drop-down menu on the website. We also want to, of course, acknowledge HRSA, their funding and support for MD Mom and the Hospital Equity Initiative work. I'll also share that MD Mom is really proud to be in partnership with all of the 32 birth hospitals in our state. The image here also comes from our website. It's an interactive map of the birthing hospitals throughout the state, and all of them are participating in some or all of our innovations. So obviously everyone here is aware of the maternal health crisis in the US. The trends in Maryland are similar to what we see nationwide, with both severe maternal morbidity and mortality on the rise. In fact, pregnancy-related mortality ratio is higher in Maryland than it is in the US. We know that as a consequence of historical and contemporary structural racism, Black birthing people in Maryland have a nearly 3 times higher risk of dying from pregnancy-related causes compared to white birthing people. Also in Maryland, unintentional drug overdose has recently become the leading cause of death in the year following pregnancy. However, our most recent report from the Maryland Maternal Mortality Review Committee concluded that 80% of maternal deaths in Maryland are preventable or potentially preventable. And so the way that the MD Mom Hospital Equity Initiative is approaching the prevention of maternal morbidity and mortality is really with the goal of building our collective understanding and awareness of the impacts of structural racism. We then hope to support hospitals to address the consequences of structural racism, which include harmful social determinants of health, as well as institutional policies and practices that may negatively impact our Black, Indigenous, and Latinx patients. So the mission of the MD Mom Hospital Equity Initiative is to support interventions that improve systems of care and eliminate maternal health inequities. To achieve this mission, the MD Mom Hospital Equity Initiative started off by offering a series of trainings to maternal health professionals in the state. The first was our online implicit bias training, as well as our 2-part implicit bias skill building sessions. We launched those trainings in 2020 and 2021. More recently, in 2022, we released an adverse maternal events training and training on bias in the care of patients with substance use disorder. We're really excited to have reached over 3,000 physicians, midwives, nurses, patient care technicians, and other frontline maternal health professionals who are working in Maryland. We estimate that more than 70% of the maternal health workforce in the state has completed our implicit bias training. And so these trainings have offered an important foundation for our next phase of the Hospital Equity Initiative, which is to launch our Maternal Health Equity Toolkit. We really believe, and research suggests, that in order to ensure truly equitable maternal health care, implicit bias training is just the first step. And so while we are really proud of our implicit bias training series, we believe that building individual awareness and behavior change is necessary for promoting equity, but it's really not sufficient. We also need systems level changes. So with that in mind, we developed the Maternal Health Equity Toolkit. Next slide. The purpose of the toolkit is to support maternal health units and departments to identify inequities in maternal care and outcomes, and to take steps to eliminate these inequities while creating a more equitable culture of care for all of their patients. The primary audience for this toolkit is maternal health unit and department leaders, as well as managers, specialists in safety and quality improvement or population health who are working in the maternal health space in hospitals. However, it's important to note that buy-in and involvement from hospital leaders and staff at all levels are really necessary to accomplish these relatively lofty goals. So I'll start by providing a bit of an overview of how the toolkit was developed. You can see this process on the left. First off, we had a toolkit development working group, which included clinicians, health equity researchers, quality improvement experts, community-based organization representatives, and patient partners. Since the toolkit is recommending that hospitals engage in authentic community and patient partnerships, it was really important for us that we build that into the process of developing our toolkit. Next, our working group curated the materials presented in the toolkit. And I often use the word curated because the information that's presented in the toolkit is really our best effort at collecting and presenting and making really easily accessible the guidance and voices of the leading experts in the field. So this includes quality improvement organizations, maternal health professionals, and Black-led advocacy organizations. And then finally, we found national experts to review and provide input on all of our content and chapters in the toolkit. They included research subject matter experts, patient engagement advocates, community-based practitioners, hospital representatives, and health equity consultants. So that process resulted in our final maternal health equity toolkit. Next slide. I'm going to pass off in a moment to Lauren, who will walk you through our content, but you can see here on the right that we really started with a set of priority areas for equity. These were adapted from the Institute of Healthcare Improvement. We then went on to identify recommended strategies. These strategies help hospitals see what they need to do within each priority area. Those recommended strategies were adopted from organizations including IHI, AIM, and the Black Mamas Matter Alliance. And then finally, within each recommended strategy, there are a set of change ideas, and these provide more granular, action-oriented steps of how to do the work. These change ideas were adapted from organizations that I already mentioned, but also from our maternal health professional organizations like ACOG and A1, other Black-led organizations like NBEC, and other quality improvement organizations like PCORI. So I'd now like to pass to Lauren to talk more about the content of our Maternal Health Equity Toolkit.
Thank you so much, Kelly, for that great introduction to our toolkit. And so I'm going to share some details about the toolkit's structure and the content of the toolkit. So our toolkit contains recommended strategies and implementation resources to support maternal health equity at the hospital, maternal care unit or department level. And in creating this toolkit, we worked really hard to approach maternal health equity as comprehensively as possible within the confines of the hospital's maternity care unit or department. And we were inspired by the Institute for Healthcare Improvement's 5-component framework to achieve health equity. And so we designed a framework, which you can see here for the toolkit, which includes 5 interrelated priority areas to achieve maternal health equity. And in creating this framework, we've really grappled with what does it take to achieve health equity within the hospital environment, what actually works, what are best practices, and how do we address barriers without acquiescing to paradigms that promote health inequities. And so it was a very long, iterative process to really grapple with all of these issues. And so here you can see on the left the priority areas for our toolkit. And those are to build a culture of equity, to promote respectful and anti-racist care, to leverage data for equity, to eliminate racism in policies, procedures, and quality improvement initiatives, and to link patients to community and social services. And in addition, you'll see that around the center of the framework, this yellow circle, there is a circle for partnership with community members, patients, and families. And we have this here because forming essential partnerships with community-based organizations, patients, and families forms the foundation for implementing the 5 priority areas of the toolkit, and it's an essential component to achieve health equity. And this really reflects one of the steps that was very important to us in order to make sure that we're creating structures and systems that at the end of the day are really going to empower the voices of people who experience inequities and who have the expertise to help us address them. And so now Naylin Harris, who's a community-based perinatal reproductive health practitioner and community-based organization leader, is going to share more about how the toolkit supports these equitable partnerships.
Thank you, Lauren. So I really want to also highlight when forming the essential partnerships in the community-based organizations, also with patients and families, is that it really required us to lean into some level of intentionality, right? And so for us to really honor how we all can kind of co-collaborate and co-create what is quite possible. When we're leaning into essential partnerships with community-based organizations, patients, and families, we're actually looking at how it provides an adaptable strategies to establish equitable partnerships with CBOs, patients, and families. And that we also wanted to ensure that it was written in collaboration and truly honoring the expertise of the CBOs, the patients, and the families. And we also wanted to highlight, the distinction. Oftentimes when we talk about CBOs, there are different variations of CBOs. There are those that are impact organizations that are doing the work every single day, who are also private practices. They can operate as lactation specialists, perinatal therapists, perinatal educators, through and through. Then we also have the social sector organizations that are oftentimes in connection to the health institutions or organizations in cities and states, who are oftentimes working hand in hand. But we really wanted to honor how there is this particular distinction as we're thinking about CBOs and partnerships. Next slide, please. So why partner with CBOs? Because they really communicate the needs and the perspectives of the community. They're usually deeply ingrained in community, and there's an intentionality there. And they also serve as a model for non-hierarchical organizational structures. And then why partner with patients and families? Because it helps us build health equity initiatives that reflect the patient's values and their preferences, and that it also nurtures trust in healthcare organizations. Next slide, please. We leaned into 4 essential practices for respectful collaboration, which that we really wanted to use community engagement principles to structure the partnership. We wanted to recognize the particular limitations and leverage institutional resources. And then appreciate that patients, families, members of CBOs, and members of the healthcare team may have equally experienced trauma in healthcare environments, and that we wanted to use the continuum for community engagement to achieve health equity, to develop, strengthen, and evaluate partnerships. Next slide. And so for the continuum for community engagement to advance health equity, the different stages is that we have the ad hoc input, the structured consultation, the ongoing involvement, and the collaboration and shared leadership. All of this required us to all collectively lean into one another and honoring each other's collective support and analysis. The ad hoc input is the community representatives complete a survey. They can participate in a focus group and informally share input on an initiative. The structured consultation is where community representatives serves temporarily on a committee or offer structured support on an initiative. The ongoing involvement is representative serves as standing members on committees or advisory councils. And the collaboration and shared leadership is where community representatives co-lead initiatives through bi-directional collaboration with equal representation or decision-making power. Next slide. And for, so how this all looks, we have the stage on the continuum, which becomes the structured consultation. The partnership strategy is where we invite CBO leaders and practitioners to lead learning activities for the healthcare team. And then the key steps and the considerations become that we ensure that, one, you have a budget to compensate CBO leaders and practitioners. We really have to honor how there is oftentimes a disconnect between funding people who are doing the work every single day in their communities who get less funding to some of our more conventional institutions, that we equally identify CBO leaders and practitioners in community with expertise in a topic that the healthcare team needs to learn more about, and that we share your topic of interest with the CBO leader or practitioner, welcome their input on the topic and learning plan, that we ask CBO leaders and practitioners if there are additional learning topics that would improve care for the people they serve, or their community-based educational events that members of the healthcare team can attend. And I'm going to pass it back over to Lauren.
Thank you so much, Tanae. So now I'm going to talk a bit about the toolkit chapters and discuss the strategies and implementation approaches for each priority area. And before I do that, I want to emphasize again that across each priority area, so within each chapter, the strategies presented require collaboration with patients, families, and community-based organizations, and guidance on how to do that is provided. And on the following slides, as with this one, you'll see the objective for each priority area, and I'll describe some of the chapter content that supports that objective. So for this chapter on building a culture of equity, the chapter objective is to foster a workplace culture of equity, diversity, inclusion, and belonging that is supportive and reflects the desired care environment. And this chapter contains strategies to lay a foundation for working on maternal health equity by creating a workplace environment and culture that reflects the equitable care environment we desire for our patients. And now that's an easy aspiration to state, but how we actually achieve this is quite complex. And the chapter takes on this complexity by sharing actionable steps to create a formal commitment of resources, funding, and staff to work on health equity. The chapter is also about accountability and creating structures to report and address racism and bias, both between colleagues and between patients and members of the healthcare team. And this chapter also addresses workforce diversity and the need for healthcare teams that reflect the patient population we serve. And through this chapter, I think we really help to create a vision for how to create that environment that will support our work on maternal health equity. The next chapter is on promoting respectful and anti-racist care. And this is about helping the healthcare team to develop knowledge and skills to provide anti-racist and respectful care. It's also about creating an enabling environment for that care. And we appreciate that it's not enough to just do training on bias and racism and be done. The healthcare team really needs ongoing learning opportunities And respect and anti-racism have to be integrated into the systems and processes that guide care. And we need support figuring out how to translate that training into practice. This chapter addresses the misleading use of race instead of racism as a risk factor and offers strategies to increase the respectful use of language services and reduce discriminatory use of security and law enforcement on maternal care units. The next chapter is on leveraging data for equity, and this is about using data to identify and address maternal health inequities. Despite the overwhelming amount of data in our EMRs, collecting, stratifying, and sharing hospital data on health inequities is challenging and often makes it hard to even start health equity initiatives and to begin to understand how health inequities show up within our institutions. This chapter offers concrete guidance on collecting and stratifying quality measures by race, ethnicity, and language preference. It also offers guidance on how to present the data in a way that promotes health equity instead of reinforcing racist and discriminatory narratives about the root causes of health inequities, which unfortunately is something that happens very often, and we have lots of opportunities to change that and to help change our perception of what is really causing these health inequities. The chapter also has strategies for expanding the sources and scope of data collection, and that gets into really understanding the patient and the community's perspective to ensure that we measure the factors that are most relevant to achieving health equity. The next chapter is on eliminating racism in policies and quality improvement initiatives. And this is about transforming how we create a safe and high quality care environment. The chapter addresses the evidence that policies, procedures, and quality improvement initiatives often unknowingly fail to reduce health inequities and can even make them worse, which is something that we're just coming to appreciate because understandably, I think most of us would assume that if you create a policy to improve care or you implement an initiative to improve the quality and safety of care, that will benefit everyone. But unfortunately, if we don't tend to health equity, we can unintentionally create more inequities or just continue to perpetuate them. And the chapter offers strategies to consider and integrate health equity when doing routine tasks, such as updating your visitor policy or implementing an initiative to improve the management of postpartum hemorrhage. And then the final chapter is on linking patients to community and social services. And this chapter is designed to take us out of our comfort zone where we primarily focus in the hospital on our patients, on their clinical conditions, and on working with hospital-based healthcare teams. In this chapter, we go beyond that and try to address social determinants of health and holistic and culturally relevant care. And the purpose of this is to extend our care so that we promote health equity, understanding that we cannot address all of the maternal health inequities just by working within the healthcare system. And we really need to partner and respect and uplift the agencies and practitioners outside of the hospital that do a phenomenal job working on this. And so this chapter is about building relationships with community-based perinatal reproductive health practitioners that extend and expand the quality of care that our patients receive in a way that can directly impact health equity. And this can include culturally relevant lactation consultants and mental health providers and perinatal loss counselors and doulas. And we do this also to try to address and make sure that we're assessing for and addressing social determinants of health by partnering with social service agencies and community organizations that help to address these upstream factors that contribute to health inequities. And now I'm going to pass to my colleague, Brianna, to talk a little more about how the toolkit is structured.
Thank you so much, Lauren. Yeah, so I'm just going to give you a little more detail about how we go about accomplishing all of these objectives within the structure of our toolkit. So we've talked a lot about the priority areas and what's contained in them. The next level in our organizational hierarchy is recommended strategies. And as Kelly shared earlier, our recommended strategies are drawn from the Institute for Healthcare Improvement, the Alliance for Innovation on Maternal Health, and the Black Lives Matter Alliance. Each priority area or each chapter in the toolkit has 1 to 3 recommended strategies. And I'm using our first priority area, build a culture of equity, as an example here. So this priority area has 3 recommended strategies. The first is to make a formal commitment to health equity and anti-racism. The second is to increase accountability to address bias and racism in patient care, healthcare team interactions, and unit culture. And the third recommended strategy is to ensure an equitable and diverse workforce that reflects the patient population. So to build a culture of equity, which is our first priority area, these are the overarching strategies that we recommend a hospital unit or department implement. And now I'm going to get even a little more specific in our hierarchy. Each priority area has recommended strategies, and those recommended strategies are what we think you should do. Then each recommended strategy has change ideas, and the change ideas are our instructions for how to go about achieving the recommended strategy. And each recommended strategy has 2 to 4 change ideas. So just to continue with our build a culture of equity priority area example, we said that the first recommended strategy is to make a formal commitment. The first change idea associated with this strategy, so the how of making that formal commitment, is to establish a health equity committee that includes diverse representation. Often toolkits stop at the level of change ideas. They have recommended strategies and change ideas, but they don't necessarily have additional instructions. Early in the toolkit development process, before we even started conceptualizing the structure, we asked representative target users for Maryland hospitals what kind of toolkit they find the most helpful. And they were really clear that the toolkits they like the most are ones that are clear and action oriented. So we created this toolkit always considering usability, and we focused on providing very practical and actionable guidance. To that end, within each change idea, we present action steps with instructions, questions to prompt reflection and inform planning, and exemplars to adapt or follow. So finally, just to finish up with that same example from the previous slide, for the change idea, establish a health equity committee, we provide guidance for how to decide on committee membership, how to outline a committee purpose statement, and prioritize key strategies for advancing health equity. And here, now that I've just explained a little bit more about how our content is organized, I just wanted to give you an overview of the recommended strategies that didn't make it into my example. I won't read all of them, but you can see here that they're progressive and action oriented. And Lauren went over this a little bit before, but just to make it crystal clear. So if you take, for example, to promote respectful and anti-racist care, you first need to increase healthcare team knowledge and skills to provide anti-racist care. And then you need to integrate respectful care practices into the routine delivery of care. So that's sort of what I'm trying to communicate as progressive and action oriented. And so, having taken a bit of a deep dive into how our toolkit is structured, I'm going to hand the presentation back to Lauren to talk about how our toolkit's content aligns with regulatory guidelines that are very important to hospitals.
Thank you, Brianna. So as Brianna mentioned, we're going to talk about regulatory guidelines. And of course, regulatory guidelines matter to our hospitals. They often dictate what our hospitals prioritize and put funding and resources towards. And so we're pleased to see that our toolkit aligns with the Joint Commission's recent requirements to reduce healthcare disparities. And so right here, you can see the statement from the Joint Commission that explains the rationale for their 3R report on reducing healthcare disparities. And it makes the point that healthcare disparities are a quality of care problem, and that strategies to address health disparities need to be integrated into existing quality improvement activities. And that is exactly what we are striving to achieve with this toolkit. And we really hope that by using this toolkit, institutions will be able to prioritize and integrate health equity into their routine processes. And I'm going to talk more about that on the next slide. So the overarching goal, that is one level of synergy in terms of this report, but there are other levels of synergy, which you can see on this slide. So the Joint Commission has 6 elements of performance to reduce healthcare disparities, and they're listed in an abbreviated form on the left. And our toolkit has recommended strategies that happen to address each of JCAHO's performance requirements to reduce healthcare disparities. And for each of our recommended strategies, we again have instructions on how to implement the strategy with key steps and resources. So for example, the first element of performance for JCAHO is to have the organization designate an individual or individuals to lead activities to reduce healthcare disparities for the organization's patients. And as part of our toolkit, we have a recommended strategy that can be implemented through making a formal commitment to health equity and anti-racism. So users of the toolkit can help achieve this performance measure, number 1, by implementing this recommended strategy in the toolkit. And you can see that for each of their elements, we have recommended strategies that address them. And one difference, though, between our toolkit and the Joint Commission's requirements is that the toolkit is focused on the hospital's maternal care unit or department level. That's where our initiatives primarily occur. They're not organization-wide efforts. While this is the case, the toolkit still has relevance and utility for organization-wide efforts, and that will help it, I think, with meeting some of the JCAHO requirements. So some toolkit recommendations, understandably, can't be achieved just by working within the maternal care unit, and they require broader organizational participation. And often throughout the toolkit, we encourage collaboration beyond the unit or department level to implement toolkit change ideas. Often you have to leverage leaders from the QI department or from the C-suite in order to make sure that things happen effectively. And in addition, initiatives to improve quality of care on the unit or department level, they can also serve as models or pilots for the broader organization. And now I am going to tell you a little bit about how we are introducing this toolkit in a way that, that will support hospitals to implement our toolkit. So another component of the toolkit is to share it through a community of learning. And we're launching this community of learning next month, and participating in the community learning is an opportunity for hospital-based maternity care units to sign on through team leaders and learn how to implement the toolkit strategies with the support of our MD Mom team and other colleagues from maternity care units across the state. And we're really excited to be able to provide this year-long facilitated community of learning through which we will learn a lot about the toolkit, and we hope that many of the toolkit's interventions will begin to come to life within our hospitals. I'm going to pass now to Tanae, who is going to talk more about the framework for the community of learning.
Thank you, Lauren. So yes, we had decided to really lean into an opportunity to build a framework utilizing Dr. Barbara Love's Developing a Liberatory Consciousness. And although it's kind of listed as pillars, this is also very cyclical, which is also how we're seeing the community of learning of it's not going to be a linear path, but it really will be a cyclical path that we will constantly go back and continue to learn together and evolve. And so first we saw with awareness, which involves developing the capacity to notice, to give our attention to our daily lives, our language, our behaviors, and even our thoughts. It means making the decision to live our lives from a waking position. Analysis requires every individual to not only notice what is going on in the world around them, but to think about it and theorize about it. That is to get information and develop their own explanation for what is happening, why it is happening, and what needs to be done about it. Action, which proceeds from recognition that awareness and analysis alone are not enough. There can be no division between those who think and those who put thinking into action. The action components is based on the assumption that the participation of each of us provides the best possibility of gaining justice for any of us. Accountability is concerned with how we understand and manage this opportunity and a possibility for perspective sharing and also working in co-collaboration so that we can begin to disrupt it. Next slide, please. And so we're thinking about it like, how do we build awareness to historical and present day racism and its effects on health and expression in the healthcare system, that we understand that our awareness is a necessity of community and patient partnership. Our accountability is where we establish a diverse and inclusive health equity committee with community representation. The analysis prioritizes key health equity strategies and change ideas. And then action, where we demonstrate progress towards implementing at least one toolkit change idea to be able to get us onto the next progressive way forward. And I will pass it over to me, Brianna.
Thank you so much today. So our community of learning structure reflects the awareness, accountability, analysis, and action objectives that Tanae just reviewed and that we respectfully adapted from Dr. Love's framework. So using IHI's model for collaboratives, we broke the year into 4 periods, an introductory period and then 3 action periods. During the introductory period, we'll be building a shared knowledge and awareness about the impact of racism on health and healthcare, the necessity of community partnerships and health equity initiatives, and how the toolkit and community of learning will help maternal health units expand their approach to equity. Then in each action period, we provide education and coaching to support hospitals to achieve each period's objective. So every month we'll have a virtual learning session and we'll provide as needed technical assistance between learning sessions. And throughout this, we're trying to build community among the participating hospitals. So like Tanae was saying, this is a cyclical and iterative process as much as we are picturing it as this 1-year trajectory. So these are the expectations for our participating hospitals. They need to assign 2 ideally multidisciplinary co-leads who commit to joining all community of learning sessions and devoting time outside of sessions to implementing the objectives. They need to commit to sharing progress, achievements, strategies, and challenges in monthly sessions and in surveys. And they need to commit to the objectives of each action period. So establishing a diverse and inclusive health equity committee with community representation, prioritizing toolkit strategies and change ideas, and demonstrating progress towards implementing at least one of those change ideas. We say at least one, but obviously we would be more than happy to support them to implement as many change ideas as they can in this period. We're excited to have 6 hospitals already enrolled in our community of learning. These hospitals represent 5 counties and 3 regions of the state. They vary in level of care and birth volume. And we look forward to facilitating toolkit implementation with this diverse group so that we can learn from the challenges and successes encountered in different settings and bring this knowledge to bear on future iterations of implementation. We really hope to build any lessons learned into both the implementation plan for perhaps future cohorts of the community of learning, and also into the toolkit itself. So finally, I'll close by just talking a bit about how we plan to evaluate the community of learning. Here I'm showing you a somewhat simplified version of our logic model for evaluation. So on the left, you have the high-level determinate constructs, which are drawn from implementation science guidelines. And then to the right, you see our implementation strategy, which consists of the toolkit itself, the establishment of our community of learning, facilitated monthly meetings, coaching calls, and other forms of support, and the use of evaluation and iterative strategies to track outcomes. And then these strategies are what enable the mechanisms to the right, which include building technical knowledge and capacity among community of learning participants, partnering with CBOs, patients, and families, and achieving the objectives of each priority area of the toolkit. These mechanisms are how we achieve our outcomes, which flow from short to long term, moving down the box on the far right. So we're focusing for our evaluation on implementation outcomes, which include reach, effectiveness, adoption, implementation, and maintenance. And we are going to measure these outcomes using surveys, both a pre and post test, and then as well as surveys tracking implementation progress throughout the community of learning, and also program data like call notes and things like that.
Great. So thank you to Tanae and Lauren and Brianna. We just want to wrap up today by saying that there are many people to thank and acknowledge. Thank you to everyone here today who's joined this presentation and shown their interest. Thank you to Andrea Krianga, our PI for MD Mom, and Sarah Meyerholtz, our HRSA program officer, who have supported this work. But there are also so many people who really contributed time and expertise to the development of this toolkit and our community of learning, most of whom I hope are listed here on this slide. And we just want to note our warmest gratitude and thanks to everyone who had a big and small role in making this toolkit a reality. It's been some years in the making. So with that, I think we would welcome your questions. I see that there are some in the Q&A, which I'm happy to get started with, and several questions about how we access the toolkit. So we currently do not have a link to the toolkit. We hope that that will be available in the fall. We are working right now with a design company, a great design company, to really help work on the design of the toolkit so that it's as sort of approachable and easy to use and understand as possible. So we're just putting some finishing touches on the design, and also finalizing the web hosting of the toolkit materials. So we hope to have that in the fall. I did talk to Leah, and we can do one of two things. We can put an email in the chat. If you want to email us, we can keep a list of people who are interested in receiving the link when it becomes live. And we're also happy if people want to put their name and email address in the chat. Leah will get those names for us and we'll keep them, and we're happy to send you an email when the toolkit is live online. There's also a question about whether the community of learning is limited to those in Maryland or open to the US. Our HRSA funding is for a state maternal health innovation program in the state of Maryland. And so the community of learning is available only to the Maryland hospitals who are here for the currently. There's another great question here, and I'll invite my colleagues to chime in on this. Someone asked, in the framework and in a majority white population, how do we notice, analyze, and act without falling into the white savior mentality, which can be just as harmful as the pre-action state? It's a great question. And again, I'll maybe see if any of my colleagues want to start in responding to that.
Sure. I mean, I think one is realizing that one for us, as we're looking at this, we are looking about space in place, right? So although we're looking at it from statewide, we also understand that there's particular dynamics within each hospital setting. So part of that is about the relationship building and cultivating, which is part of what we're looking for the community of learning. So again, we were talking about it wouldn't be a linear path. We would really be looking at the group as a whole, looking at it on individual, personal, interpersonal, and systems levels. And then that will help guide and facilitate how we do that work. So we will be able to identify those who are showing up, kind of centering, let's just say, kind of the white gaze or the white savior complex, and being able to help through the particular framework of being able to honor how we can actually achieve the ultimate goal of really creating a more equitable and justice-oriented way for the state.
Thanks, Tanae. And Leah, I don't know if you could pin all the panelists, but Lauren or Brianna, anything to add?
I'll chime in. I think it's a great question and something that I think comes up a lot. And I would say we hope that the way the toolkit is structured by guiding you to work and collaborate with patients and families and community leaders and community-based organizations that experience health inequities, that through that process, you will follow their lead. And so there will not, you won't be able to present yourself as a savior, because that's not your role in this process. You're really listening to and following the lead and expertise of communities that experience inequities. And you can do that through those partnerships. You can also do that by engaging in the literature and that is written by individuals who experience inequities. And yeah, just continuously centering their expertise and hopefully diversifying your team also.
Thanks, Tanae and Lauren. I think Leah is uplifting. She opened the chat for me so that people could put their emails in and I could capture them, but she's reminding us that we should try to use the Q&A for questions so that because it's a little hard to see them in the midst of all these emails. I see a question about, could you share the process you use to operationalize equity and anti-racist care for these hospital settings? Yeah, and then, okay. Lauren, do you want to say anything, or would you like me to?
I don't know that I fully understand the question, but I think the toolkit is that process, is our work of operationalizing equity for the hospital departments.
Mm-hmm. And I think, in the community of learning, it's hard to do everything in a toolkit. In the community of learning, a lot of what we will focus on is sort of awareness building around sort of the breadth of what those concepts mean. And in each chapter of the toolkit, by carrying out these different strategies and change ideas, I think you are the idea is that you are working towards the promotion of equity and anti-racist cares and systems of care. I hope that, feel free to put another question in the Q&A if that didn't fully answer your question. Somebody asked a question about how to engage community-based organizations. Let me see if I can. So can you reshare how you outreached and partnered with community-based organizations? So, I think there's sort of two levels to this, and I would encourage maybe Tanae and Brianna could be pinned as well, Leah, because they may have something to add here. In terms of the development process, it really has had to do with relationships, like getting to know communities and developing relationships with various community-based organizations, being curious, asking questions, and getting to know folks who are doing the work. In terms of how we operationalize that or ask hospitals to do that, I don't know if Lauren or Tanae wants to comment on that, how hospitals can outreach to and partner with community-based organizations as we've instructed them in the toolkit.
I think I was processing the first iteration of the question, which I think part of this was what we do also talk in the toolkit is what it means to actually lean into uncomfortability. And there are people who are intentionally trying to build some levels of equity within the hospital setting. And so leaning into the researchers and the scholars and really looking at those who are Black and Brown who are equally affected by this, who are also taking notice and working in collaboration. So part of this is moving away from levels of comfortability and leaning into relationship building and cultivation. And so taking notice to the folks who are actually doing the work in community. This also requires us to move away from moments where we lean into building relationship with those who we find ourselves being most comfortable with, right? Sometimes we want to cultivate relationship with community leaders, community-based organizations that we might find more palatable as opposed to those who are leaning and trying to get us to a levels of systems change. So I think us being able to kind of identify, so it's like one, whether it was us, the Bloom Collective in Baltimore, and being able to see that there are 20 other organizations who are deeply rooted in community and uplifting and amplifying their names, knowing that we're not the only one, right? Anytime, I will say this, I purposely saying, if you ever meet someone who says they're the only person and you know that there are others, I would say, really lean into the fact of organizations that can really see the gift, the talent, and the genius of other folks who are rooted in community, who honor that they're not the only one. And for us to really lean outside of our comfortability to really try to get to a level of systems change.
Thanks, Tanae. We have a few more questions here. There's one that's asking whether or not we'd be interested in partnering with other states on this toolkit. And I would just say maybe we could answer that offline. Brianna could drop an email address in the chat for you to reach out to. So feel free to reach out to Brianna and we'll respond. Another question says, rightfully so, this is focused on maternity care hospitals, given that half of perinatal mood and anxiety disorders are the largest complication of pregnancy and that at least half of these come after the labor and delivery. Is there any information to incorporate perinatal individuals after labor and delivery? Any linkages to pediatric settings, other touch points? I'm happy to speak a little bit, but Lauren, anything to say?
No, I just think it's a great question, and something that we definitely work on in the toolkit is thinking about how do we best create those partnerships and linkages and ensure that we're extending care through the great providers that we have in the community, and also integrating those providers into our setting when feasible.
Yeah, so that is the focus of one of our chapters, the linkages to care, to community and social services. I would also say that the sort of long-term vision is that this might be, if it's successful in working with hospitals, a long-term vision is that the basic information in the toolkit is actually pretty transferable to different settings. It would need some adaptation, but I think we hope to be able to move into ambulatory care settings at some point in the future. Because again, it's a great point that we know that lots of maternal health and contributors to maternal health happen outside of the labor and delivery and postpartum unit setting and care. I am establishing my nonprofit for helping postpartum women. Would you recommend approaching nurse unit managers or going through a higher channel to gain partnerships for referrals? That's a great question too. I don't know, Tanae, do you want to take a first attempt at that?
Yeah, I mean, it's always how are things looking where you are? But I'm one for the more relationships that you can build, the more accountability there is, right? So there is a kind of that structure, that hierarchy. So you can talk to one person, they talk to you and it goes nowhere. But here, if you talk to multiple different people and you kind of build that level of allyship and folks operating at levels of solidarity who really want to build systems of equity, I believe that's really where you can start building and cultivating deeper and meaningful relationships that allow for accountability to make manifest. So I hope that answers a little bit of question. I mean, I know that that's part of how we've attempted to pivot, of how do we look at all of the different relationships throughout the ecosystem that allow us to navigate, to be able to create, you know, the level of change or transformation that we believe is needed and necessary for our communities and for our clients.
And Brianna or Lauren, anything to add?
I'd just say, I think hospitals aren't great at this, and that's something we're trying to help them do a better job at.
Yeah, and I think Tanae's point is like very well taken, that like I would say like, yeah, definitely email the nurse manager, but if you don't get a response, don't stop there. Find other people who are, you know, part of that maternal health system and continue to develop those relationships. And yeah, and I think there will be forward progress. So good luck to you. Will a baseline be established for each hospital to later compare or evaluate the impact of the toolkit? If so, how will that baseline be determined? Any of my colleagues want to take that, or should I? We're all smiling a little bit because we are really like right now in the midst of like trying to just really think deeply about the evaluation, and there are sort of multiple elements of the evaluation, right? It's how does the toolkit reach different hospitals? How are they using it? So there's sort of these implementation science questions. And then there are questions for each hospital, as you're noting about developing a baseline. We certainly hope to work with them around data, right? One of our chapters is data for equity, and being able to establish, you know, some of their primary maternal health outcomes stratified by various race, ethnic, language variables. Having said that, we really want to meet hospitals where they're at. And we know that some hospitals are, say, already doing that, and some hospitals are very challenged by that. And so I think we will be working with them on setting those benchmarks, but may not be requiring that of them, if that makes sense. I will also say that there are things with respect to equity that are more policies and procedures that will take, you know, may not have immediate impact on some of those like major maternal health outcomes, right? And so how do we track and see how those are also meaningfully impacting patient experience of care, staff experience on the unit, and so forth. So there's sort of a variety of, I think, important indicators. Brianna, do you have something to add?
I guess I'll just add that for our initial evaluation, we will mostly be focusing on reach effectiveness, adoption, implementation, and maintenance of the toolkit strategies and change ideas, mostly because these are measurable within our context. We obviously would like to be impacting on the more distal or long-term outcomes, things like satisfaction with care, equitable patient health outcomes. These are a little more difficult just from an evaluation perspective to attribute to something like the toolkit. So yes, we are definitely establishing a baseline for each hospital, and also that baseline will likely initially at least focus on things like implementation outcomes.
Thank you. I think that may be all the questions and also the end of our presentation time. So thank you to Leah and NMHIS and my colleagues, and to everyone who joined us today.
Thank you.